Do I start, Anil? It's 6:30. Okay. Good evening, friends. Welcome to this Delhi Liver Foundation Symposium on Systemic Therapy in Hepatocellular Cancer. When, how, and for whom. I have a very knowledgeable and very wise moderator with me, Professor Sanjay Satpathy, who is a very well-known hepatologist from US. You know everybody. He is very well-known in India. And over a period of time, the knowledge on liver cancer has expanded and exploded. And we have not only identified a high-risk population for patients with liver cancer, we have identified the risk stratification. We also know that detection of liver cancer at the early stage is curable. However, in most part of the world where resources are limited, the most of the liver cancer do occur. That is Africa, Far East, and Asia. Even in the developing country like US and Europe, despite resources, the incidence of liver cancer is on the rise, obviously because of various lifestyle diseases and patients suffering from hepatitis C who are pre-existing, as well as alcohol. Now, there is a large group of patients who are presenting in advanced stage and not in a curable stage. And most places do not have screening technology or surveillance for high-risk patients to detect treatable cancer or curable cancers. They present in advanced stage. Over a period of time, the molecular drivers of liver cancer has been identified, and intervention against these molecular drivers are at vogue. Now, to discuss this management of this group of patients, which are the majority of the patients globally, we have brilliant speakers, elegant speakers, who will be discussing on various aspects or treatment of this advanced cancer, because there are many therapies or drugs now available and has been cleared by the FDA as well as world over to treat this advanced cancer, albeit not to cure them, but to improve the qualitative as well as quantitative life. I'll request my friend and moderator, Dr. Sanjay Satpathy, to invite the speakers and introduce them. Sanjay, please take over and invite the speakers and kindly give them a brief introduction.
Hello, everyone. First of all, I would like to welcome for this very interactive session that will be happening in the next few moments. The topic of discussion today is systemic therapy in HCC, when, how, and for whom. We have eminent speakers, as Dr. Acharya already alluded to. And to begin this, I'll be inviting Professor Anil Arora, who is currently working as the chairman at Department of Gastroenterology and Hepatology at Sir Gangaram Hospital in New Delhi. As you all know, he is very well known, not only in India, but across the world, and even well known in USA as well. I would like to invite him first to give the talk on molecular mechanism of HCC in relation to systemic therapy. Before going forward, I would like to also introduce the other eminent speakers and briefly, and then I'll go forward from there. Our second talk would be indications and choice of drugs in advanced HCC. This will be given by Dr. Singhal, who is an associate professor of medicine at the University of South Dakota, Sanford School of Medicine, and transplant hepatologist at the Avera Transplant Institute. In addition, he also directs the hepatology elective course for the senior medical students at the Sanford Medical School and is the Chief of Clinical Research Affairs at the Avera Transplant Institute. He's with clinical and translational research interest in alcohol and non-alcoholic fatty liver disease, renal injury and cirrhosis, and porphyria. Dr. Singh's research has been funded by American College of Gastroenterology, NIH, and pharmaceutical industry. He has over close to 200 original paper, peer-reviewed articles in national and international journals and book chapters. I would following that, we'll have a discussion on role of combinations with systemic therapies in HCC. This will be given by Dr. P.N. Rao. Dr. P.N. Rao is in the AIG hospital in Hyderabad. And following this, we will have the final talk about limitations of current systemic therapy and future perspectives by Dr. Bob Giss. Dr. Giss is a close friend of mine, is currently an adjunct professor of medicine at the University of Nevada Schools of Medicine in Las Vegas. He serves as the adjunct professor of pharmacy at the Skaggs School of Pharmacy and Pharmaceutical Sciences at UCSD, California, in USA. He completed 3 years of internal medicine residency at the University of California, San Diego, and 4 years of gastroenterology and hepatology fellowship at the University of California, Los Angeles, which included transplant medicine. Dr. Giss is a fellow of American Association of Study of Liver Disease. Without making it any further delay, we would start with Professor Anil Arora, who will be talking about molecular mechanism of HCC in relation to systemic therapy. Professor Anil Arora, over to you.
Thank you, Sanjay. Are my slides visible?
Yes.
Okay. Thank you, Dr. Acharya and Dr. Sanjay, for giving me this opportunity. The topic of my presentation is molecular pathogenesis of hepatocellular carcinoma, especially in relevance to today's topic of systemic therapy in advanced hepatocellular carcinoma. HCC is now the 4th most common cancer causing mortality in the world, as estimated by WHO. 60 to 70% of these cases tend to occur in the Asia-Pacific region because of association with the viral type of hepatitis, which is the major reason for development of hepatocellular carcinoma. Despite advances in the outcome of HCC and the research which is associated with it, still the prognosis is dismal. 2-year survival in hepatocellular carcinoma is only 50%, whereas only 10% of the patient will survive more than 5 years. Most of the patients, by the time they present to us, they are unfortunately in the advanced stage of the disease. If you look at the worldwide distribution of hepatocellular carcinoma, it does parallel to the prevalence and incidence of the various types of viral hepatitis, be it in the Europe, North America, Asia, and Africa region. Even in countries like US, major component and major proportion of HCC is still 50% is still related to hepatitis viral infection, which are not only treatable but are today totally curable. Cirrhosis, which is present in almost 70 to 90% of the patient, is the major driver for development of hepatocellular carcinoma. In fact, it is the single largest risk factor in development of hepatocellular carcinoma. The various factors include HBV infection, HCV, heavy alcohol consumption, non-alcoholic steatohepatitis, and hemochromatosis, which I have highlighted. In fact, the very fact that if you have hemochromatosis, you have a 200 times more risk of developing hepatocellular carcinoma than any of other known etiologies. In spite of the fact that we have good antiviral drugs available for hepatitis B and C, still we are not able to substantially reduce the incidence and the prevalence of hepatocellular carcinoma. In fact, over the last 20 years in US alone, HCC has increased by almost 140%. And we are glad to have Dr. Sanjay as one of the proponents of HCC research joining us today for this program. Now, how does HCC develop in patient with a normal liver? In a normal liver, you will first have chronic inflammation, be it because of hepatitis or non-hepatic factors like alcohol or NASH. With passage of time, untreated, unabated inflammation will lead to develop. At some point of the time, during attempts to regenerate and degenerate, you will develop dysplastic nodules, which will turn into an early HCC. This is the time when if we catch hold of the disease process and we can nip it in the bud, but unfortunately, By the time the patient lands up to us, the patient already has an advanced hepatocellular carcinoma. So a normal liver can be damaged because of these reasons. And at some point of time, during the process of regeneration and degeneration, there are molecular mechanisms in the form of MYC, TGF amplification, IGF overexpression, or HERT overexpression, which lead to development of dysplastic nodules. And once you have suppression of the tumor suppressor genes, primarily P53, which is an extremely important component of pathogenesis of HCC, you tend to develop hepatocellular carcinoma in the early stage. And by the time you have HCC, there will be a plethora of molecular mechanisms, which will not only lead to progression of the disease, but will also lead to spread of the disease. And that is the time, unfortunately, poor patients come to us for help in management of hepatocellular carcinoma. In fact, if you look the way a normal liver gets injured by these noxious agents, be it B, C, alcohol, NASH, or aflatoxins, so you will have an injury by the normal physiological mechanism. The body will try to overcome it with repeated attempts at regeneration and degeneration. In the bargain, you will have stellate cell activation that leads to abnormal deposition of the fibrosis and the fibrotic material, resulting in formation of the cirrhosis. At some point of time, these regenerating nodules do become autonomous, leading to dysplastic nodules. And during the course of the illness, you will have loss of tumor suppressor genes, resulting in formation of hepatocellular carcinoma. All this may be related to telomerase inactivation. There is a substantial role of inflammation which promotes carcinogenesis. Whatever the etiology of noxious injury to the liver, there are two ways by which inflammation can trigger malignancy. The first and foremost is if you have inflammation that, because of the presence of both damage associated molecular patterns as well as a pathological associated molecular pattern, will lead to stimulation of the pro-inflammatory cells, which will lead to activation of the NF-kappa B pathway, which is important for activation of the mitogenic pathways within the nodule, regenerating nodule, leading to the formation of the tumor cells. At the same time, when inflammation is occurring, you will have a simultaneous injury onto the DNA of the hepatocytes in the form of either DNA damage occurring directly or because of the epigenetic phenomena, because of the viral integration in the case of hepatitis B, or oxidative stress because of any injury, especially alcohol, and persistent inflammation in and around the DNA lead to genetic changes which result in formation of the tumor cells. And mind you, these tumor cells on its own lead to formation of large amount of NF-kappa B and STAT3 activation, which again lead to both redevelopment of the tumor as well as non-resolving inflammation. So you have inflammatory cells which are secreting pro-inflammatory cytokines, which activate these pathways primarily in the form of c-Jun and JNK pathways, which have both cell proliferating action as well as anti-apoptotic action. Second mechanism by which inflammation causes HCC is that in a normal course of the events, if you have any cell which is exposed to the incoming pathogens, either in the form of DAMPs or PAMPs, so this normal monocyte will respond by release of these substances called interleukin 12 and interferon gamma. This will lead to stimulation of the M1 type of macrophages, which produce pro-inflammatory cytokines. So they will be causing activation of the immune system, as well as they will tend to be tumoricidal and microbicidal. But what happens once you have tumor occurring in patient with cirrhosis of the liver? It has twin problem. First of all, tumor itself is releasing these cytokines called IL-4 and IL-13 and IL-10. And at the same time, they are recruiting tumor cells and other monocytes into the tumor environment. Now, once you have a tumor cell which is recruiting the monocytes, these monocytes are more preferentially likely to be directed towards the M2 type of macrophages. M2 type of macrophages are more likely to have T helper 2 activation, resulting in angiogenesis, phagocytic activity as tumor modeling and regeneration. So what is happening is that you have a system in the body or a liver which is getting tolerant to the immune system. How does it occur is that once you have macrophages, they are producing more of Th2 response, which will try to stimulate the Treg response. Once you have a Treg response, there will be suppression of the dendritic cells and suppression of the immune system, as well as upregulation of the Th17 cells. So once you have suppression of the immune recognition cells, that is dendritic cells, which fail to recognize the antigen, you will have overstimulation of the Th17, which will be important for angiogenesis and further poor prognosis of the HCC. So two factors are simultaneously occurring. You have non-viral drivers, that is non-inflammatory damps, or you have viral drivers through the process of inflammation. So by the process of inflammation, you are stimulating the intracytoplasmic toll-like receptors, which lead to induction of the TNF-alpha and IL-6. These are potent pro-inflammatory cytokines. They are known to stimulate this STAT3 type of supranuclear factors, which lead to angiogenesis, which lead to oncogenic transformation of the dysplastic nodules. Similarly, the non-viral factor, through the help of inflammasomes, they are trying to suppress the apoptosis. So two things are occurring. So you are decreasing the apoptosis, thereby decreasing the killing of the abnormal cells. At the same time, you are letting the normal cells proliferate, resulting in formation of the hepatocellular carcinoma. So there may be different mechanisms in the different type of etiologies. In hepatitis B, depending on what stage does the patient come to you, be it in the early chronic hepatitis phase, chronic liver disease, or in an early HCC, various different pathogenetic mechanisms may come into play. You may have inflammation, you may have redox potential or oxygen free radicals, which may be causing the injury. There may be telomerase reactivation, or there may be HBX, which is causing stimulation of the proto-oncogenes, or there may be integration of the virus, which is causing suppression of the P53 or tumor suppressor genes. In hepatitis C, primary problem is that you have a virus which is giving you a lot of antigens which are acting at different levels for transformation of the dysplastic nodule into a pre-neoplastic or early HCC. This could be in the form of ROS, persistent chronic inflammation, stimulating angiogenesis. These are the various antigens of hepatitis C which are playing different roles at different points of time in the natural history of the disease. Similarly, in alcohol, you have combination of the reactive oxygen species and activation of the activated protein and TLR signaling, which are important for causation of hepatocellular carcinoma by the various mechanisms that I have shown. Surprisingly, in NASH, you have plethora of problems which can cause HCC. In fact, of all the disease processes, this is the one lesion which causes the maximum incidence of hepatocellular carcinoma. The mere presence of hyperinsulinemia acts through not only the pro-inflammatory cytokine components, but also through the endocrine mechanisms by increasing IGF as well as by increasing androgen. You are able to stimulate a lot of proto-oncogenes which lead to hepatic carcinogenesis. So irrespective of what the stimulus is, this is the tumor cells which need stimulation of the nuclear receptors at the surface. Then you have intermediate number of receptors which will take the signal from the surface down to the nucleus. And in the nucleus, you need to have activation of the beta-catenin, c-MYC, and c-Jun, which ultimately lead to proliferation and survival of the cells even in the adverse conditions. Whereas at the same time, you are trying to suppress the tumor suppressant gene, of which P53 is a classical example. So if we are trying to develop drugs against proliferation of the tumor cells, you need to block the endothelial cells with the receptors. You need to take care of the PD-1 antibodies, which are trying to bind the PD-L1 ligands onto the tumor cells, or else you block all the receptors which are present on the surface of the hepatocytes, which are abnormal in the form of HCC. So these are the various drugs which have limited and different efficacy and action against the receptors which I have shown you. If you see, lenvatinib is one drug which has large number of actions against so many receptors present onto the surface. So the key genetic events in HCC include, you need to have suppression of the tumor suppressor gene. This is very important in patients on aflatoxin exposure, especially aflatoxin-B1. You have beta-catenin activation, which is extremely important in HCV-related liver disease, and you have EGF receptor stimulation, which gives you relevance in terms of aggressiveness of the tumor. The more the expression of the EGFR, the more will be the metastasis and the tumor. So this is what happens in patients who have hepatocellular carcinoma. You have large number of the receptors which are present onto the surface, and these, because they are autonomous, they do not need the help of the body. They have autocrine stimulation, so they are important for survival, differentiation, proliferation, and invasion of the tissues. Similarly, on endothelial cells, you have large number of the receptors which are important for proliferation of the surrounding vessels, stroma, mesenchymal tissue, so that the tumor is making merry at the expense of the body. So you need to have drugs, and one of the drugs like lenvatinib may have multitude of the action. It will have action against host of the receptors onto the surface of the hepatocytes of the tumor cells, as well as on the endothelial cells. So you may have multitude of the action. Whether it is useful or not, I'm sure the further speakers will be talking in detail about it. Any role of immunotherapy strategies in hepatocellular carcinoma? Before understanding that, I think it is extremely important to know the basic science of tumor detection. So this is a normal antigen presenting cell. Once it has to recognize a foreign cell as an abnormal cell, it has to use a TCR signaling mechanism with the help of co-stimulatory interaction. Once it is stimulated, you will have activation of this cell, which is going to get rid of this abnormal cells. But unfortunately, what happens in hepatocellular carcinoma is that in normal course of the events, this is the dendritic cell, which ideally should recognize the new antigen, which is coming from the tumor. So this is the tumor antigen, which should be recognized with the dendritic cell. And this dendritic cell should present this tumor antigen along with MHC1 onto the surface. And then this should get attached to the T cell receptor, which is present on the T cell. So what should happen is this should get activated and T cell should get rid of the tumor cells by recognizing this antigen. When T cell is trying to recognize this abnormal antigen, it does require the services of this co-stimulatory molecule. Unfortunately, if you have ligands attached to the tumor cell in the form of ligands against CTL4 or PD1, these T cells do not get activated and they are not able to cause apoptosis or killing of the cells. So if you give a drug like CTLA4 inhibitor like ipilimumab, you're able to get rid of the abnormal cells in the form of HCC cells. So with stimulation of these cells, the normal cells can be turned into a cytotoxic cells. So this T cell receptor will recognize the antigen presented on the tumor cell along with MHC and will be counted as an abnormal cell. Now, the only blocking points in between the cytotoxic T cell and tumor cells will be PD1 and the PD1 ligands. So if you're able to counteract PD1 by the antibodies called nivolumab or pembrolizumab, or by counteracting PD-L1 ligand by durvalumab, you may be able to induce a lot of perforins and granozymes, which are going to lyse the tumor cells and get rid of the tumor cells. So what happens in normal course of circumstances in any cancer is that the tumor cells, they tend to develop newer antigens called tumor-associated antigen. And during the course of the illness, newer and newer antigens keep developing. The older tumor cells, which are differentiated, they keep getting out, whereas the newer cells keep proliferating, and hence the tumor gets perpetuated. So if you can have an adoptive cell therapy, that means if you stimulate the autologous lymphocyte with cytokines or tumor antigens, using either the cytotoxin-induced killer cells or infiltrating lymphocytes, you may be able to generate modified T cells, which may be able to recognize these abnormal cells. One of the new concepts of treating based on immunopathogenetic understanding of HCC is something called chimeric antigen receptor cell therapy. What it means is you take out a T cell from a person who is infected with HCC, bring it out, insert a gene which codes for a specific new antigen, be it GPC3 or CMET or PD-L1. And once that has been inserted into the T cell, you grow millions of these cells out in a in vitro fashion. And once you infuse this is called CAR T cell therapy for immunotherapy of HCC, then it is presumed that part of the cells which are able to pick up these antibodies against the antigen present onto the surface of the HCC may be lysed. Similarly, on the same basis, we may be able to develop a vaccine against hepatitis C if you're able to identify the antigens which are important onto the surface of the hepatocytes, which are turned into malignancy, which are responsible for generating the immune system. So to sum up, in patients with cirrhosis of the liver, you have plethora of noxious agents which are trying to not only cause cirrhosis of the liver and repeated attempts for degeneration and regeneration. At the same time, you have a persistence of inflammation leading not only to the direct injury through the activation of NF-κB pathways, but also causing microenvironmental changes directly and indirectly affecting the genetic and epigenetic changes in the DNA, resulting in the formation of hepatocellular carcinoma. So if we can understand the molecular pathogenesis of HCC, I think the manipulation of the host immunity by HCC allows it to flourish undetected and have multicentric presentation because of the inflammation and underlying cirrhosis. Both of these in terms of persistence are extremely important in causation of HCC. Traditional surgery, chemotherapy and radiotherapy is followed by high recurrence rate, and hence a good knowledge of the proliferative pathways and immunotherapy has shown efficacy in delaying the progression of the advanced tumors and protecting post-op patient against the recurrence of the cancer. So a good knowledge for further development of multiple TKIs and nivolumab and other immunosuppressive agent is extremely useful. With that, I'll stop sharing my slides and hand it over back to the moderators.
Well, Sanjay, I think take over. You invite.
This is truly an elegant talk, and I think this is a way Dr. Arora always talks about the pathophysiology and pathogenesis in such a simple term and such a complex topic. I mean, truly amazing, and I hats off to you. We can probably have some questions at the end of this. All the topics are deliberated, and then we'll go over and having some questions, and we'll go for the discussion at that point. I will next invite Professor Ashwini Singhal to talk about systemic therapy for HCC, indications, choice of drugs at this time. Professor Singhal, please.
Well, thank you, Sanjay, and thank you, Dr. Acharya, and organizers for this opportunity, especially Anil. And I would agree completely with Sanjay on his compliment to Anil on taking a difficult topic always and making it so simple, and making the second presentation easier for me. And at the outset, I would like to acknowledge that I'll be giving kind of a flavor of what are the drugs available as of today for treating advanced HCC in a systemic fashion, and how we can choose these drugs in treating our patients in a much better way than we probably did a couple of years ago. Here are my disclosures, and none of them is related to the presentation today. So over the next 15 to 20 minutes, we'll learn what are the effective systemic treatment options available for advanced HCC, and how we can identify patients suiting to a particular regimen, and then recognize that treating hepatocellular carcinoma, especially today, is a multidisciplinary approach if we talk about advanced hepatocellular carcinoma. So here is the landscape of systemic therapy in HCC. So over 10 years, sorafenib, as you can see, kind of a monopoly in treating systemic treatment for hepatocellular carcinoma until we got this frontline therapy this year got approved, which is a combination of VEGF inhibitor and an immunotherapy for the treatment of hepatocellular carcinoma. And in the course of time, especially around last 2 years, there have been many, as Anil pointed out, not only multi-kinase inhibitors, but also a lot of immunotherapy options which have been approved by the FDA for the treatment of hepatocellular carcinoma. So we may not be at the best of the times, but definitely much better time in treating our advanced patients. So taking you back almost 10 years or 11 years, we know that this study published a decade ago on sorafenib compared to placebo in advanced hepatocellular carcinoma. And we all know that there was about 3 to 4 months survival difference, with a median survival of about 11 months with sorafenib and 8 months with placebo, and the drug got approved. And since then, we've been using this for treating our advanced patients for chemotherapy. And about 2 years ago, this study REFLECT was published comparing lenvatinib, another multi-kinase inhibitor, and Anil showed you the multitude of actions of lenvatinib. And this was compared to sorafenib in this randomized open label, and this was designed as a non-inferiority study because sorafenib was not eligible for many patients or not tolerated with many patients. So looking for an alternative. And this was close to about 1,000 patients of hepatocellular carcinoma in an advanced stage, either BCLC-B or C, and then child PUA. And remember, most of the trials have enrolled child A and BCLC stage B or C. And this particular study excluded those with portal vein invasion. And as you can see, it was non-inferior. So in a way, it was a negative study, but actually it was designed as non-inferior. So I would say it was a positive study. And lenvatinib gave about 14 months of median survival time. And then, but the difference was that I think this is an important aspect of this particular study, which was kind of a evolution in how we evaluate clinical trials in hepatocellular carcinoma. Because we're looking at progression-free survival and also, more importantly, the objective response rate. And this was using the IMbrave criteria on CT scan. And you can see that lenvatinib, although non-inferior to sorafenib, but was much superior in terms of how the tumor was responding to treatment on CT scan. And this included partial as well as complete responders to the treatment. And that way lenvatinib was superior, and that got approval for as an alternative treatment to sorafenib in the treatment of hepatocellular carcinoma. And since then, objective response rate became a kind of an important secondary endpoint, and you would see in this particular trial also, which is, I think, the game changer in the treatment of hepatocellular carcinoma, published May of this year in New England Journal of Medicine, where atezolizumab and bevacizumab combination. Bevacizumab, we all know, is a VEGF inhibitor, and atezolizumab is an immunotherapy. And this was compared to sorafenib, which was a frontline treatment until then. And this was again a phase 3 study based on encouraging response to phase 2. And you can see that the 500 patients were enrolled in this particular study. Overall survival was the primary endpoint, and then the progression-free survival and objective response were secondary endpoints. And the doses are listed over here of each arm and the number of patients in each arm. And mind it that all the patients were again child PUA, ECOG performance status 0 to 1, and BCLC stage B or C. And here are some flavor of the baseline characters. So about 7th decade, most of the patients, about 80% males, and half of them were in Asia and half in the rest of the world. And you can see about ECOG either 0 or 1, majority child PUA, majority A5, and BCLC-B or C stage. And they did have patients with AFP more than 400 in about a third of these patients. And about 60% of these patients did have some kind of either a portal vein invasion or microvascular invasion or an extrahepatic spread. And about a quarter of these patients had varices, and we'll talk about the importance of varices in this regimen. And then there were all the etiologies were represented, hepatitis B, hepatitis C, and other causes of hepatocellular carcinoma. And here are the response rates for the regimen compared to sorafenib. And as you can see, as early as 6 months, the curves are separating out in favor of the combination therapy compared to the sorafenib, and for the first time a regimen came superior to sorafenib, and you can see the hazard ratio below 0.6, which is highly significant. Sorafenib. And based on this trial was halted early because of such a good signal, to the extent that median survival was not even reached in the treatment arm or the combination arm, and it was over 17 months in this particular study. So what about the safety profile, which everybody will be eligible for this combination? I think the major issue is about the bleeding because of the way bevacizumab acts. So there is always a risk of inducing upper GI bleed in patients who have advanced varices or large varices. And you can see it was about 7%, in spite of that screening everybody with varices within 6 months of the study enrollment, and treating varices before the patients were exposed to the medication. Still, there was 7% risk of upper GI bleeding compared to 4.5% in the sorafenib arm. So that's the catch, and screening strategy in clinical practice also, that many patients may not be suitable for this regimen. And then another thing is these immune-related adverse effects, and someone who is already having some autoimmune disease may be a relative contraindication for this kind of regimen. And as you can see, the grade 3 or grade 4 serious adverse events, as expected, were more in the sorafenib group in terms of the GI side effects and hand, skin, foot reaction. But the immune-mediated side effects, grade 3 to grade 4, were more common in the atezo-bev group, whether it is hepatitis or nephritis or some kind of other skin rash and other immune-related adverse effects, which these patients can happen during the course of regimen at any time. So once we know that the frontline treatment became this combination treatment, so what about patients who are not eligible for this regimen? Do we have alternative to those patients? And more importantly, in the course of time, patients who are not tolerating sorafenib or who are not responsive to sorafenib. There are 3 trials here we have listed. I have listed the resource trial, which compared regorafenib versus placebo in sorafenib tolerating patients, but unresponsive to them, about 600 patients. And regorafenib was superior to sorafenib in terms of the median survival time of about 11 months versus 18 months. And similarly, the other medication here, which is cabozantinib, which is a multi-kinase inhibitor, again about 700 patients, turned out to be superior to sorafenib. And this was a group of patients who were sorafenib intolerant patients. And this is a ramucirumab trial, and I want to mention here about 300 patients, and all of these are phase 3 studies. And this was again superior to sorafenib, again intolerant patients. But if you look at the original trial, was
Now is the director of hepatology at the Asian Institute of Gastroenterology, very eminent personality. Looking forward to his talk, looking over this scenario. Professor Rao, please.
Yeah, over to you. Yeah. I think my first, thank you very much, Dr. Anil. And first, my apologies, because I think I have read this title a little bit wrongly when I was been listening to the previous speakers, and I think I have read it totally wrong in the sense that role of combination therapies, which involves the drugs which are available. I did not realize that it is with the loco-regional therapy along with the systemic therapies. and therefore, but the last moment I will not be able to say, but that can be covered in this one. So there will be some amount of major repetitions will be there, but having prepared that, I have to go through that one. My apologies. And then this is because perhaps we did not talk to each other. I didn't talk to him. My apologies for that one. Anyway, as already been Dr. Singhal, and then everybody has elaborated on that one, on the role of combination therapies in HCC, is a sort of, I was thinking that the symposium, since it's a symposium on systemic therapy, it is mainly the drug combinations, which I was I thought alluded to, since it's been covered so elegantly, Dr. Singhal. And as we know, but one thing which is very important here, what is apt today in the treatment of HCC may not be the same in future. This has been clearly been identified recently by the way FDA has given an approval for the combination of pembrolizumab and lenvatinib in 2019, and then it's withdrawn in September 2020. So tomorrow, when you talk about it, it may be an entirely different scenario. And the why we should have a combination therapy, we have a cytotoxic chemotherapeutic drugs, we have molecular targeted therapies, and we have these immune checkpoint inhibitors. It's been clearly
share the slides, please.
Pardon?
Can you share your slides? We're not seeing your slides.
Not seeing slides.
Yes.
I feared. Oh, okay, I'm sorry. You're able to see now?
Yeah, and if you, yes, we're seeing your slides.
Yeah, that's right. Okay, but the role of a combination therapies in hepatocellular carcinoma, and since this is a symposium on the systemic therapy, I was mainly concentrating on the role of the combination of these drugs rather than the combination with the loco-regional treatments. And we know that with the experience which we had with the other viruses and also with the non-alcoholic fatty liver disease, that only one drug or one drug is not sufficient, and then we should have a combination therapies in many of the diseases, and then HCC is no exception for that one. And why should you have a combination therapy? And this, we have these cytotoxic chemotherapeutic drugs, we have these molecular targeted therapies, which have just been alluded to, and the immune checkpoint inhibitors. It's been clearly seen that in the randomized trials with the anti-PD-1 monotherapy, either in the first line or in the second line, did not demonstrate a statistically significant improvement in the overall survival. On the other hand, the preliminary results and then early phase results has indicated a superior response when these combinations have been used. That means either anti-PD-1 or anti-PD-L1 and anti-CTLA-4 or other antigenic molecular targeted therapies. And here I have given in a nutshell what could be the possible combinations among these with the advanced HCC. On the left-hand side panel, you are seeing these programmed death ligands and then the programmed death receptors, and the drugs which are responsible for that one are here, the nivolumab, pembrolizumab, durvalumab, and atezolizumab. And the CTL4, that is the cytotoxic T lymphocytes associated protein, it's also known as CD152, and the drugs are ipilimumab and tremelimumab. On the right-hand side, you got these molecular targeted approaches, which we know that has already been alluded to. All these drugs are very familiar. And the combinations with the PD-1 or CL4 or the combinations with the immune-based approaches with the molecular targeted approaches are the ones which we have already gone through, which I'm going to just reiterate them. And Dr. Anil has already told you about this. That is, by blocking the CTLA4 and the PD1 blockade, we are facilitating the immune checkpoint inhibitors to act upon. And here we have the molecular, the VEGF inhibition drugs, which as I said already, at various stages, they are being active here. And with let me go back to the sorafenib era. At this time, we have got a cytotoxic chemotherapies with cytotoxic chemotherapies, and we have a cytotoxic chemotherapies with the sorafenib and then other targeted drugs. And way long ago, people did try the systemic chemotherapies or hormonal therapies in advanced hepatocellular carcinoma, including the doxorubicin combination with the PIAF, that is cisplatin, interferon, doxorubicin, adriamycin, and 5-fluorouracil, and the other combinations. And the hormonal therapies have also been tried, but there has been a dismal response and there was no proven efficacy. And these are the cytotoxic chemotherapies which have been tried in hepatocellular carcinoma. You can see on the left side, doxorubicin, capecitabine, and these are monotherapies, and these are polytherapies, combination therapies, and none of them have really succeeded. And they did make a lot of trials of these. And after the sorafenib has come, and then after the sorafenib, people have started combining the chemotherapeutic agents with the sorafenib. And one of them, which is prominently, was doxorubicin plus sorafenib, and then sorafenib alone. But this was interrupted after a planned interim analysis demonstrated that a higher toxicity in the combination group, and because the primary and secondary endpoints were not met. And here you can see that the doxorubicin and sorafenib combination with the sorafenib, and there's been no advantage, and these chemotherapeutic agents in association with these molecular targeted therapies has largely been given up long ago. And sorafenib with the other targeted drugs, and all these are failed phase 3 trials in the advanced hepatocellular carcinoma. But one of them, which is combined with this sorafenib with the erlotinib, and again I can see that this is a failed one, and then the median OS did not differ from the sorafenib. And these are some of the drugs which have failed already, and the adding erlotinib to the sorafenib did not help. Unlike the conventional cancer therapies, the immunotherapeutic approaches do not really directly target the tumor cells. They target the patient's immune system, as already been discussed with Professor Anil, the tumor microenvironment, and out of these we know that the immune checkpoint blockade. And these ICBs have been the focus of the cancer chemotherapy, not only in hepatocellular carcinoma, in most of the other cancers as well. And what is the scientific rationale behind these immune-tolerant checkpoint inhibitors and the anti-VEGF? There are 4 roles have been proposed, that is recognize, recruitment, reprogram, and restore. The recognize the anti-VEGF by inhibiting the VEGF-mediated suppression of the dendritic cells, which has dendritic cells, as Anil has emphasized, very important in the immune components, and enables the efficient priming and then activation of the T cell responses against the tumor antigens, and recruitment of the more by the infiltration by the T cells into the tumor, and reprogramming, there is a reprogramming of the tumor microenvironment from immune suppressive to immune permissive, and restore, and then the immunomodulatory effects of the anti-VEGF mediated immunomodulatory effect are going to be added to the immune checkpoint therapies. And the preliminary results from the early phase clinical trials indicated superior response rates and duration of the responses when anti-PD1 and then anti-PD1 ligand agents were combined with the anti-CTLA4 or anti-angiogenic molecular targeted therapies. And there are empty number of drugs, as you can see here, that these are the early phase trials of the immunotherapy combinations in HCC. And some of these trials have been, most of the trials, some of these have completed, which have already been alluded to Dr. Singhal, that is atezolizumab and bevacizumab versus sorafenib. I mean, I will not go into the details of that one because it's elegantly discussed the intricate aspects of this particular drug combination. And this has already been told, and then what we can see here that the ones which have been the atezolizumab and bevacizumab, and for the second line therapy, nivolumab and then ipilimumab are the ones which has been recognized by the FDA recently. And you can see here that the single agent nivolumab has, although it was recognized earlier, but the responses have been much greater with the combination therapy here. And this combination of which has already been discussed here, the bevacizumab is an anti-angiogenic agent with additional immunomodulatory effects. And then in combination, this will further enhance the ATI's efficacy by reversing the VEGF-mediated immune suppression to promote T-cell infiltration into the tumor. And this is the first phase 1 study, and then with the combination of ATI and bevacizumab. And later they have added, because they would like to compare the combination with ATI alone. And it's been clearly been shown here that ATI alone is not sufficient. As you can see here, that the median PFS is 3.4 versus the combination, and then which is about 5.6. And these are the drugs which we have already been alluded to. And this combination has been approved in the month of May here. And this is the one which has been alluded by Dr. Singhal, that's in New England Journal of Medicine. And this has been considered as a groundbreaking because the earlier nivolumab and pembrolizumab, both programmed cell death PD-1 antibodies, have failed to show the efficacy as a first and second line therapeutics respectively in the phase 3 clinical trials. And this is the first time since sorafenib that immunotherapy with the combination of these two drugs resulted a better survival than the treatment with the sorafenib, and that's the reason this has been considered as a groundbreaking. And I shall not go into the details because this has already been, summarizing the overall survival at 12 months is 67.2 as compared to sorafenib, which is 54, and median progression-free survival 6.8 months as compared to 4.3 months. And what requires to be seen is the side effects, and then which we have to remember that the hypertension is particularly mentioned as one of the side effects, and therefore one has to monitor those kind of things. And later, FDA approved the nivolumab plus ipilimumab advanced hepatocellular carcinoma for the previously treated with the sorafenib. And the first arm A has been found to be useful as compared to the arm B and then arm C. As you can see here that I think we should get accustomed to these terms like the better overall response, disease control rate, duration of response, medium OS, progressive disease, stable disease, all in favor of in the form A, in the arm A. And later, this ongoing one, which is comparing the sorafenib and then lenvatinib and then same combination here. And this is the one with the FDA grants the breakthrough therapy designation to PEM and lenvatinib in advanced cancer in 2019. But in September 2000, it rejects the same combination as the first-time treatment. And it is issued a complete response letter. And then I would like one of the Sanjay or somebody to explain us what meant by the complete response letter. And this is, of course, they're not recruiting anymore. That is the lenvatinib plus PEM combination. And then in comparison with the lenvatinib or placebo. And these are some of the things which are still ongoing. And the future prospects are the ones within the combination therapy, that the evidence of a combination with the loco-regional therapies is yet to come. As on today, that the loco-regional therapies and then combination of any of the systemic therapies have not been found to be useful. And we will have a more discussion on this particular. And therefore, after nearly a decade, 5 positive phase 3 trials, the new drugs in the HCC that's been shown to improve the overall survival time. And then ATI and then BEVA is the first one, as you can see here, that has been the one which has been found to be superior to sorafenib after nearly 10 years. And for the lenvatinib, has already been told, the first line. For the second line, Regora, Cabo, and then ramucirumab have been. And therefore, the combination therapies which have been alluded to have, sorry for the repetition, but we can have some amount of a discussion with the local regional therapies and this combination. Over to you. Thank you very much.
Thank you, Professor Rao. Again, that was an excellent talk. And especially we're talking about the combination therapies, which is now evolving. And the best combination appears to be the ATI and vivacilimab combinations. And I think we'll learn more and more as the trial results are to come along. But also we need to understand now the limitations of the current systemic therapy and what are the future perspectives. I would invite Professor Robert Gase to deliberate on this. Professor Gase.
Thank you very much, Sanjay, and the rest of the speakers for having me here today. I want to wish everybody a good evening. It's morning here in San Diego and looking forward to some beautiful weather and more safety. I'm going to just get my slides set up and one more switch. Are my slides looking good to everybody? Well, the event so far has been absolutely wonderful. I've learned a lot, molecular mechanisms, different types of therapy, monotherapy, combination therapy, and I had the wonderful opportunity to set up what are the limitations and what are future issues. I'm going to call these current and future issues. I work with a number of the different companies in the liver cancer space, and my website has a lot of resources for liver cancer as well. Gaps that I won't be covering today are listed on this slide. We obviously are focused mainly on systemic therapy, so I'm going to talk about what opportunities are in our current environment. Things have been very exciting over the last 30 years in terms of understanding HCC. And most recently, the targeted therapies and systemic therapies have really changed that later stage. And one deficiency that was present 5 years ago was oncologists really were not involved with liver cancer management, maybe even 10 years ago. This has changed dramatically where just about every oncologist in the world is aware of the systemic therapies and the availability of these compounds. Liver cancer management is still 3- and 4-dimensional. These 2-dimensional tables, such as the BCLC management, are good, but patients are often moving between these different phases quickly. And most patients are actually getting combination therapy up front, such as a combination of TACE and thermal ablation, which is standard for all of our patients with relatively small tumors. So one deficiency, one gap is updating this type of diagram to be much more 3-dimensional and the dynamics that are taking place with combination therapy. You heard a lot about these therapeutic targets in HCC. Well, I think that pharmaceutical companies were lucky because they came out with what were determined to be multi-kinase inhibitors and also with our checkpoint inhibitors. They really got to liver cancer by accident. So I'm hoping that one of the deficiencies can be corrected in that we are actually designing drugs for liver cancer, or we're targeting our medications not at the fact that we have an HCC, but at the tumor specific characteristics. I'm going to talk quite a bit more about that, although you had a great introduction from Dr. Aurora. This is a little bit of an older table, but I want to highlight the median overall survival of these compounds was absolutely, I think, terrible. So major gap has at least been partially filled because the IMbrave study, for instance, may have a median survival of nearly 30 months, and a lot of the other new combination are in the 24 to 28 months. So, but one of the, I think, targets of some of these new therapies is actually to eventually cure HCC. All we're doing with our current systemic therapies is buying time, so to speak. We really need to come out with medications that have a much lower adverse event profile. dropout rate from sorafenib from the Gideon study was very, very high. It was a real-world study looking at dose reductions, dose discontinuations due to adverse events. I think this is also going to be very much the case with all of our current evolving therapies, which have a variety of adverse events. And if you think about our study design for these systemic therapies, they're all in child's A patients, at least up to A6. We have a little bit on B7. We really have almost nothing to offer our patients with B8 and above in that CTP category. Treatment strategies are listed here. I agree with the previous speakers that this is going to be combination therapy with what I call AB therapy first, with lenvatinib in the COVID times being first-line therapy for patients who do not have access to infusion centers. They're not able to gain that type of therapy in person, but could be managed potentially by telemedicine. This is the EASL guidelines. Along the left is level of evidence. Along the bottom is level of recommendation. I really disagree with one major part of this, which is Y90. I understand that Y90 has issues on limits on availability and cost. And there were the SARA study, there's a SERVIB study that compared Y90 to sorafenib, and they called those studies treatment failures. Yet Y90 was non-inferior or equivalent to sorafenib in those studies and had a much lower adverse event profile. So I call those studies a treatment success, and I would be moving Y90 to another part of this table. Well, you've heard a lot about combination therapy. I want to say, yes, we're missing a lot of information, but in the next 12 to 24 months, these combination studies, especially phase 3 studies, are going to come out. And I think all of our patients will be treated with combination therapy, not just for small tumors such as TACE plus thermal ablation, but systemic therapies will be almost universally combination therapy. So we need to get this data to our clinic. Along the right side is what we could be doing in terms of public health and primary prevention. We have a number of major gaps there, and that's why so many patients present with late-stage disease. But the deficiencies we have right now is not, we are not able to profile our HCC patients because we no longer biopsy patients. LIRADS was a fantastic advance in terms of making a diagnosis without tissue, but we really need to be going back, I believe, to getting tissue biopsies for targeted and non-targeted therapies. And I'll be talking about some of those mutational signatures and cancer drivers shortly. Liquid biopsy, I think, would be quite useful, but we need to be able to determine PD-L1 and PD-1 status through blood tests. And I think that may be improved with a special technology called a Velcro technology that we could talk about during the discussion. Well, these genetic mutations that you heard about from Anil during his presentations evolve over time. And I'm going to talk about another major issue in a moment, but these major mutations, which there's 40 to 60s in the HCC, show that this tumor has extreme heterogeneity. And that may be one of the reasons why we have probably $3 to $4 billion US that have invested in targeted therapy or systemic therapies, and yet many of these have failed, such as the brivinib compounds. Another area I'd like to highlight is this extreme intratumoral heterogeneity that is present. It's a clonal issue or a multi-clonal issue. Each clone has its own characteristic. So will biopsy of the direct tissue be sufficient? Probably not. We may be doing multi-sampling, maybe doing FNA, or may come back down to circulating tumor cells, circulating tumor DNA, microRNA vesicles to determine what's happening in the liver. And of course, it's not just these clonal expansions that are taking place, but there's interactions with extracellular matrix. You've already heard a lot about the immune system, and I'll be developing a little bit more on that shortly. This is a little bit more on genetic heterogeneity. The upper left graph highlights these mutational signatures with p-values. On the right side, I'd like to highlight that not only are we having mutational changes that result in deletions, but also in gains. Those gains potentially could be targetable, but we're going to talk about that in just a moment. So these most common, such as TERT, the CTNN, ARID, AXIN, are considered unactionable now, that we don't have agents. And there's a perception within pharma that these can't be directly targeted with new therapies. I believe this will change, but if you look at the right graph, we have a major problem because only 20% of patients or 25% of patients have actionable targets. The HCC microenvironment is very, very heterogeneous. We talked about stroma, interaction with fibrous tissue. You can, by looking at pathology, have a somewhat on a subjective level prognostic changes, and this eventually may become useful in terms of determining what therapies to apply. This microenvironment is very, very important, but here is very, very important research, not only came out from Yovet, from the New York, Spain collaboration, but also in this article in Gastro, that it's the surrounding tissue that's very important. I'd like you to look at the second line down in that surrounding issues, which is these CD8 T cells. It's like CD8 and CD3 may actually help us determine the immune environment and may actually eventually allow us to choose what type of immune therapy to provide. This new integrated classification looks at a little bit more simplistic model of proliferation class on the left and non-proliferation on the right, with some very specific molecular structures and clusters that are present. We have differences in chromosomal instability, and this heterogeneity, I think, will need to be further defined in terms of prognosis for the patient and what agents that we're going to be using. We're very much hoping that this liquid biopsies will allow us to sample what's happening in the body and in the tumor without doing repeat biopsies on our patients. Extracellular vesicles are also markers of liver pathology. I think these will mature in the next few years as another part of the liquid biopsy system. Here you can see a number of microRNAs that are really sampleable by getting serum or plasma on patients. And their profiles of these are present for healthy controls as well as in patients with hepatocellular carcinoma. This may eventually guide therapy as well. So look in the lower right-hand corner of this graph, and you're looking at drug and biomarker pairs. So this is a little bit of some projection, but by sampling our tumors, especially looking at mutations and amplifications in FGF19, looking at TP53 mutations that are there, MET amplifications, we may allow us to design studies and look at combination studies as well. As you know, there was a drug called tivantinib that was being developed for c-MET high tumors. The study was well designed, but that was a failure. So even a targeted therapy at a specific change in HCC did not result in success, and we do not fully understand why. So systemic therapies available in our patients. I want to highlight the discussion you had about ramucirumab. We do have one biomarker, and that's alpha-fetoprotein. And AFP is not just a side effect of the cellular replication. AFP actually manipulates the own microenvironment around the HCC, including influencing the immune system and influencing things such as neovascularization. So ramucirumab, through the REACH study, REACH 2 specifically, was found to be beneficial in high AFP patients, although the change in survival was modest. What about candidate tumor genomic biomarker signals? Well, we talked about MET before. This is unfortunately only amplified in 2 to 6% of HCC patients. But if you add up a number of these, including FGF19, another 5 to 10% of patients, what's called TSC loss, another 10%, you're starting to see some specific tumor profiles that may provide characteristics in up to a third of our patients. A little bit more on these genomic biomarkers, talking about FGF19. Look in the lower right corner. This visogatinib it's targeted for patients that are FGF9 overexpressed. And you can see on the right side in this waterfall plot that there's substantial tumor response in a subset of patients. Immune signatures we talked about earlier. This gives a little bit more detail on the CD8 T cells and a variety of other inflammatory and immune signatures that take place. In the lower section, you can see we can stain for PD-1 and PD-L1, although in current clinical trials, this is not shown to be useful. But you have to realize in many of the clinical trials, we have very little tissue sampling. And also our stains and our ways to measure PD-1 and PD-L1 are very immature. And clearly we need to be having more advanced both tissue analyses and what's circulating in the serum and plasma. This TKIs with checkpoint inhibitor has a huge amount of science behind it. I'm very excited about these next set of studies that will be out looking at multi-kinase inhibitors in combination with checkpoint inhibitors, but we're still missing on which is the best patient for this combination. Again, there's a major gap because the research studies are undersampling patients in terms of tissue and undersampling patients in terms of serum banks or plasma banks for helping to look retrospectively at tumor response as new assays become available. Going back to a little bit more general issues, you heard in Dr. Arora's discussion, he had a point about aflatoxins. Can we actually measure those in our patients in the tissue and circulating, and would that change with that signature 24 in terms of what therapies are applied? We have mismatch repair defects. Is that going to change the therapies? We have HPV and what's called insertional mutagenesis. Will that end up changing what therapies we apply? Obviously, if you treat hepatitis B early, from 2 papers that were published at AASLD just a week ago, you decrease that insertional mutagenesis process using our current oral nucleotide analogs, such as TDF. Alcohol-related, NASH-related disease, are these not just changing how HCC develops, but eventually will they change what systemic therapies that we apply? I agree very much with the statement about multidisciplinary team management. I feel like this is also a major gap. I work in California and Nevada and a number of communities, and they're just starting to bring in hepatology into these tumor boards. They're typically run by oncologists, and we need to be able to reach these tumor boards to talk about treating the underlying liver disease in our HCC patients. This is a major gap. We have our international guidelines committees that say don't treat hepatitis C until you have the liver cancer under control or ablated. I think this is completely wrong. If you have a hepatitis C patient and liver cancer, you need to treat the hepatitis C to a cure immediately. I think the data is false that by treating hepatitis C, HCC becomes more aggressive, more pathogenic, more dedifferentiated. Treating underlying hepatitis B is important as well to improve liver function. There's a really nice abstract and paper that was presented at AASLD on treating NASH patients with decompensated liver disease with an SGLT2 and improving liver function and decreasing the severity of portal hypertension. So I think it's important to be treating NASH aggressively when you have a patient with HCC. I think this is a major gap and a place that we can move things forward. Multidisciplinary teams improve HCC outcomes. This has been shown over and over again in a number of different research studies. Let's move this to the standard of care globally through programs such as ECHO or telemedicine, telehealth. We can get multidisciplinary care to almost all parts of the world. I want to thank the Delhi Liver Foundation, my co-speakers, Sanjaya, for helping to chair this with the rest of your speakers, and I look forward to our discussion. Thank you so much.
Again, well, that
this is the next is Sanjay, the open house. If there is any questions, otherwise we will conclude and summarize the whole discussion. Please ask if there are any questions. That's what according to the program, because there is an open house discussion after that. Right. Is there any chat box, any questions?
I don't see any questions on the chat box, so maybe we can dive in and have some questions to each of the speaker.
Can I summarize that before you bring in some questions? Am I permitted to summarize the whole thing?
Yes, sir. Yes.
Well, this has been very interesting discussion with our friends. And we have all the 4 speakers providing us new information. To start the ball rolling, and Professor Dr. Anil Arora actually gave us a very interesting direction to the molecular drivers of liver cancer. He showed the synergism between the primary liver injury predominantly because virus, alcohol, or fatty liver disease, causing cell damage, matrix remodulations, DNA damage, and genetic changes, which is getting perpetuated by leaky gut, which he told the PAM, which induces pro-inflammatory cytokines, which itself per se further change the microenvironment of the tissues inside the liver, which is trying to regenerate. And third, very interesting thing added, that the change from M1 to M2, which is normally physiologically meant for repair, is used for tumor carcinogenesis because M2 causes angiogenesis, limitless replication of the cell for tissue repairs, as well as prevent migrations of the cells, and which helps in prevention of apoptosis, which is the basic mechanism of any cancer, that is formation of stem cells, limitless replications, angiogenesis, prevention of apoptosis, and migration of the cell, essential part of the liver cancer. He also provided the various molecular drivers and possible intervention, particularly in these various areas, where he pointed out intervention against molecular drivers, particularly tyrosine kinase inhibitors, which are receptors for cell proliferations. He also provided us how the liver cancer evade the immune system by PD-1 ligands, or PD-1 ligands binding with co-stimulatory molecule, hence nullifying, or helping the mechanism of opposite idol, how the T cell regulatory cell increasing CTLF4 is helping to evade immune system. So he brought in the genetic problems, the injury, the inflammation, and immune escape mechanism working together in causing liver cancer and a propagation of liver cancer. And Dr. Ashwini Singhal brilliantly pointed out that with the advent of this knowledge, now the number of drugs which are available to treat advanced liver cancer has increased. And he divided this drug into 3 lines. The first line drug, he clearly mentioned there are 3 drugs that are available. The old experience use of sorafenib, then the non-inferiority triad of lenvatinib, and the recent one, combination of atezolizumab, which is a PD-1 ligand blocker with the anti-angiogenic drug, that is bevacizumab, showing probably comparative or little better response than the sorafenib, hence has been included in the first line of the drug. And Dr. Singhal also pointed out the lenvatinib had an advantage over sorafenib, particularly in objective response rate, in progression-free survival, time to progression, and there is a subgroup, I think Ashwini missed it, those patients with alpha-fetoprotein more than 200 has a better overall survival with the lenvatinib in comparison to sorafenib, which is Masato Kudo's trial published in Lancet Oncology. Now, the second line drug he pointed out are regorafenib, particularly in those patients where with sorafenib there is progression, further progression, where the regorafenib has been added and has shown to improve overall survival as well as progression of the tumor, prevent progression of the tumor. He also pointed out those patients who do not tolerate sorafenib and there is a progression, carbogenetic is a good drug, which is a second line drug, which is used in those where sorafenib intolerance is there. Further, 2 drugs, barring lenvatinib, ramucirumab, has been found to be useful in subgroup of patients who have high alpha-fetoproducing tumor. That's what the Ashwini told us. He also pointed out that the third line agents, which are particularly immunotherapy, that is the immune checkpoint inhibitor, except against PD-1 and against CTLA-4, particularly pembrolizumab, nivolumab, and now ipilimumab, are promising, but we need more objective data. And he also pointed out when you are treating this drugs with various immunotherapy or tyrosine kinase inhibitors, you have to take care of the varices, and you have to also treat the other associated problems causing liver failure. Now, Dr. P.N. Rao actually provided a lot of further information on this combination, but overall he told the idea was whether you can combine this drug with curative treatment and prevent recurrence. That was the subject, particularly post-transplant adjuvant therapy with tyrosine kinase inhibitors, which are already established, post-ablation with adjuvant therapy, and post-transarterial chemoembolization or TARE or SBRT with the drug, whether they are helpful. Unfortunately, the evidence is poor because most of the trial has taken the endpoint as progression and not overall survival. A recent study by Masatoshi Kudo has suggested that if you don't take the endpoint as progression and take the endpoint as overall survival and continue to treat with your transarterial chemoembolization and add on this tyrosine kinase inhibitor, he has shown a median survival reaching in the BCLCC up to 36 months. This study has been published, and that is an important study where the endpoint should not be taken as progression of the tumor, but an overall survival. Now, mostly Dr. Giss pointed out the gross, despite advantage, we are limitations. First thing, he pointed out the tolerance and discontinuation of the tyrosine kinase inhibitors. And the real life scenario that many patients do not tolerate because of diarrhea, hand-foot syndrome, hypertension, and problems with platelet. And also he pointed out that even though in oncological term, the overall survival has increased, the amount of increase in survival is probably not substantial to indeed in the large area of resource constrained country where access to this therapy is out of pocket, 80%, and is an expensive therapy providing a small survival, which will be probably not very cost effective in general. That's what he's trying to say. He also pointed out that if all the registration trial has been done in child say patients and ECOG 1 or 2 patients, your majority of patients are not child say or ECOG 1 or 2. They are probably much more patient, but Anil, I, and many of us in India, in Southeast Asia, in South Asia, in Far East, in Africa, where 80% of liver cancer occurs, they don't see this group of patients are small. I will see, I remember my data from All India Institute, it is less than 15% of the total liver cancer. It increased to 25%, we started screening of high-risk patients. That's one of the major things. He also pointed out that, Dr. Giss pointed out, when you treat this patient, you treat the liver disease as well. Particularly if you have advanced varices, you may bleed and die. Now, third thing, another important thing he pointed out, molecular driver in liver cancer is not one. It is multiple. And for each tumor, the molecular driver may be varied. And the immune behavior also may be varied. And it is not practical to take biopsy from each focus to have a personalized medicine. Therefore, he emphasized on liquid biopsies, particularly to understand on immunotherapy. This genetic heterogeneity needs further evaluation, further classification. Despite the molecular pathogenetic classification of liver cancer has been available, its practical use is grossly limited, particularly for clinicians, unless it's much more simplified and practical, right, technologies, making it simple, is available to provide the benefit to people in general. He also pointed out the tumor is not only having alone, it is not only TUT, it is not mTOR, it is not P53, it is also microenvironment, right? The microenvironment also modulate liver cancer, and he pointed out the degree of fibrosis, the degree of inflammation, and microRNAs. Now, many studies has shown the tumor aggressiveness or tumor suppressions or microRNAs. And he thinks, right, this tumorigenic biomarkers, further analysis of tumorigenic biomarkers, along with liquid biopsy, may make life much more simple in this complex disease where we need a multidisciplinary approach, rightly pointed out. I thought that's what I learned from all of you, essentially, and any other further inputs or comment, you are welcome.
Doctor, I thought that my impression was that adding loco-regional therapies, the sorafenib, there have been empty number of trials and then and there are many meta-analysis and found that, and generally it's not recommended. And the latest drugs, the PD-1 and then CTL4 are still in the progress. To the best of my knowledge, I don't think anything has come out, any solid information has come out combining and then recommendations. I mean, I can...
I agree with Dr. Rao, but what I'm trying to say, I've studied all these trials, and if you see, the endpoint is progression.
Right.
Whereas they are child's A patients, but the endpoint is progression. So therefore, you are actually taking accordingly that you will get the result, and the meta-analysis will so see the same thing. The endpoint, whereas contradictory, the endpoint is overall survival in such patients. It is not only progression. You are trying them in a good patients with good liver function, and you are not giving them adjuvant therapy. In fact, that's what Japanese do. Actually, learn from Japanese that don't stop the treatment despite progression, add on the treatment, and you may stop the progression. That's the message. So let us not, and that's also the data from my own experience, which should be published, which you have done at All India Institute. I don't stop at 2 tests, continue up to 6 or 7 when they tolerate, add on sorafenib, and our people have survived more than 5 years, 6 years, they will be there. So that is the point what I could have published. I think I can send you that publications, and there's a large data. There's a Japanese data, albeit, don't deny. You need to replicate the data, but there are now indications. So the endpoint is very important when you see the registration trial. That's my personal comment. I don't contest the meta-analysis. I don't contest all these trials. I don't contest the guideline based on these studies. Yes, the guidelines, as Dr. Geese pointed out, the guidelines. The adjuvant therapy has no role, ESL recommendations, because they are based on evidence-based guidelines. But these are the questions, these are discussion which I'm opening up based on all these informations.
One of the problem actually, here, when you combine TACE or TARE along with a combination of systemic therapy, there is hesitations because of the potential side effects. So usually they do sequential rather than as a combination. So you're starting one therapy and see how the patient is tolerating, and then you can add, of course, this has also not been studied well as of now, but if we are looking forward to a combination, I think a sequential therapy, knowing the patient, how they're going to tolerate, whether they're going to decompensate after a test, and then adding a second combination systemic therapy probably is a better way to do this.
I agree with Sanjay. There will be various opinions. There are various type of combination, sequential combination therapy. But question is, it's still now, the jury is open. The debate will continue because we know very little. And we have now ammunitions in our hand, which excites clinicians to try various methods. And Professor Geese rightly pointed out that this is a disease which is a very heterogeneous disease, various bad drivers, various components. And you need to probably have a simultaneous check on all the components, depending upon the understanding. You probably need a lot of more inputs on this disease to develop various interventions, keeping that this happens in cirrhotics, where the virus is killed, the virus is killed, the liver failure, dysfunction kills, the complications further, infection kills, the systemic hemodynamic kills, over which the tumor occurs. So there are a lot of other inputs that obviously is very clear, but certain points has emerged, newer drugs has emerged, and therefore it is exciting time. Therefore this discussion and these are opinions.
I'll have a question to Dr. Gies, actually. I think he pointed out one of the very important finding or was suggested that, for patients with hepatitis C with HCC, you shouldn't hold the treatment for with the DAA. My question to you, Bob, is, there has been this hesitation come from some studies where they're saying there's just sanctuary. The tumor harbors the hepatitis C and then doesn't allow the penetration of the drug as well. And so there is a high risk of relapse. If they respond well, it's great, but the chances of relapse is higher. And that's, I think, the hesitation not to combine DA and patients with HCC to treat those patients. Tell me, what do you think about that? And I'll ask a second question as a follow-up after that.
Great question, Sanjaya. The major point here is that the cure rate with DAAs and liver cancer is in the 70 to 80% range. So you're going to help 70 to 80% of patients by improving liver function, decreasing enzymes, improving renal function, improving quality of life, and it decreases the confusion that you may have with elevated liver tests during therapy if you can remove the hepatitis C from the environment. So you're going to help 70 to 80% of patient management. If the patient relapses, they don't always relapse with resistance. So you could potentially treat them again as you're treating that liver cancer. And maybe by that time you've ablated the tumor. And if they do develop resistance, we have second and even third line therapies. So I think we can eventually cure all these people, most with first treatment, but with second or third courses in other people. Meanwhile, you're benefiting the patient. Remember, these people are infectious. There's also a stigma associated with hepatitis C. So treating hepatitis C can help the patients, I think, from 7 different perspectives. What are your thoughts?
Well, I think in contrast to hepatitis C, where there is a debate, and I agree with Dr. Gies. In hepatitis B, unless you treat with an antiviral, there is a higher recurrence rate of liver cancer. So the virus, if that cause, I think you should treat it. And the previous thinking that there is an increased incidence of liver cancers in those patients treated with DA, probably untrue because they are all cirrhotic. You used to never treat them earlier because with interferon and ribavirin because they have advanced fibrosis. So Dr. Gies is absolutely right? Because there is a large component of liver disease, which is very important.
Yeah, so the question actually comes here again to maybe anybody else also can talk about it. Like if a patient of advanced HCC you have and who is not eligible for transplant or any kind of surgical resection, now you're talking about systemic therapies in advanced HCC, hepatitis C. Now you're going to treat the tumor first, or you treat the tumor and the DA in combination, or you wait for the tumor objective response, then you treat this patient with the DA. That would be an important question to answer. I don't think it's been studied well, but still I think would like to understand that.
What I will do, I will downstage the tumor. Downstaging tumor is a big concept today. So downstaging tumor improves, gives you time. And with downstaging tumor, I will treat the virus as well. Because that's a very important component. 30 to 40% of tumor, which is not resectable, which is not transplantable, today is transplantable and resectable if you downstage it. And therefore, since downstaging is possible with the available therapy, I personally do that, right? I combine that with antiviral therapy along with the downstaging of the tumor. That's not my personal opinion because the data is not there. You need firm data on this. I don't know what Dr. Giss does or Dr. Anil does or what you do or Dr. Rao does.
I think there is a little difference, I think, because of the way we approach the transplant in the US and India, maybe, because well, the living donor is the primary,
That's
way
right.
of transplanting them. Here, now the door is open for hepatitis C positive donors, and so treating them before, if they're transplant candidate, you're downstaging them and transplant candidate, probably treatment is not necessary, but because you can treat them and get the hepatitis C organs and get these patients for the transplant. But if it's not a candidate, it's an advanced HCC, not a candidate, and you can downstage, but I don't know whether you can objectively downstage enough to get the patients transplanted. So the question at this time arises, should we treat them so that we can improve their overall synthetic function to allow them to get a treatment for the HCC with the systemic therapy?
Okay, that essentially is the same thing.
Can I ask a question, Dr. Ashwini Singhal, if moderators permit me?
Yes.
Yeah, as Dr. Acharya very rightly said, in Indian scenario, very few people come with early HCCs. So most of the patients who come to us, they are in the child BCLC, C, D, and ECOG hardly ever better than 2 or 3. And the major component of their problem, as Dr. Acharya rightly mentioned, is liver disease. And that is how they come to you, be it with ascites, anorexia, weight loss, large lump anorexia. So where is the role of oncology here? As you have been repeatedly stressing that you should have a multidisciplinary team. So we hardly have any role for oncology, or maybe we are missing it.
So I think that's an important point, and my take on that is that I think you raised 2 or 3 important points. The first point is what to do with patients who are child B or child C, as most of the trials, as Bob and I showed, that are enrolled mainly from CTPA class in most of the trials. So B8 or beyond has not been studied. But if you go back into the literature, sorafenib and some of the other drugs have been retrospectively studied in this population. So my take is, if you encounter a patient with, say, for example, child B, 9 or 10, maybe sorafenib may be a better option as a frontline therapy and not use Eto and Bevo combination. So that may be something to consider. The second point you raised about patients who have decompensated disease and have complications like ascites and other issues which can kill the patient, and very important point. And I want to congratulate and thank Dr. Acharya for summarizing the talks so well, so well. I've never heard such a nice summary from a chairperson and a moderator as Dr. Acharya did. Very nice job done. Thank you, Dr. Acharya. So the point of having complications from cirrhosis and liver disease, I think, is very relevant, because when we talk about overall survival as a primary endpoint in a clinical trial, we're missing that part, because patients could die not from cancer but from complications of cirrhosis. And that is why I think FDA and other investigators brought objective response and progression-free survival as important endpoints, not only for analysis of the study but also as basis for FDA approval. As you saw, some of the drugs were approved, even the overall survival was not different, but objective response rate was different. For example, lenvatinib and nivolumab. And lastly, about the multidisciplinary approach, especially related to oncology. And I agree, if you're using sorafenib alone, I think we hepatologists are good enough in managing patients on sorafenib. But I think more and more, when you use these oncoming drugs and combination therapies, maybe oncology would become part of the team, apart from radiologist and pathologist and hepatologist and other members of the team. As Bob Gish pointed out very clearly, that tumor genetics is going to become more and more into playing a role in selecting the drugs for right kind of patients to improve their response rates. So, but your point is well taken, Anil, that if you're using sorafenib alone, maybe you don't need to involve oncology. You can manage the patient's liver disease, tumor, get radiologists into the team for interpreting. I don't know what Bob and other think.
Well, actually, Anil, there is a real-life study called Gideon study, published in Liver International long back, if you remember that. And the Gideon study says, in fact, sorafenib has a marginal benefit even with BCLC B and C patients. And that's a real-life scenario of multicentric study. And but the tolerance, as Dr. Gies pointed out, the cost, right, and discontinuation of the drug is a big problem, right? In these patients who are invariably more than epoch 2, right? Then the sarcopenia is a problem. Their ascites is a problem. The infection rate is a problem. Their varices are the problem. They have multiple problems. And that's why Anil is pointing this out to us. You have seen these patients yourself. Sanjay, you have seen this patient yourself during your training period, right? They are absolutely a different ballgame altogether. And that's why he points out how does oncologist helps. And remember, our oncologists are general oncologists. You need hepatic oncologist. Specific, there is a branch which should evolve, what I call as a hepatic oncologist, understanding about the liver disease as a whole. You are all hepatologists and you understand how complex liver disease is. And that's why Anil is raising this question.
I think that's an important point which Subrata, you're raising, that involving an oncologist which is interested in liver disease is relevant. And we at our place, and I think Bob's place also, tumor boards in hepatology usually have an oncologist sitting.
That's very important.
And in a group of 12 or 13 oncologists, we always see 1 or 2 oncologists coming repeatedly to these tumor boards, because the rest 10 may not have interest in liver disease, and those 2 may be more interested in liver disease. And now, as Bob pointed out, HCC is being represented even in oncology tumor boards because these specific drugs and more special drugs are coming.
That's right. That's right.
That is true, actually. Here as well in Northwell, we have a specific hepatic oncologist, as you said. There's special tumor board that we have every week, and specific hepatic oncologist who is only interested in HCC, nothing else.
That's right. That's what we need actually in India.
Yes, I think that needs to be developed as now that so many drugs are available, so more complexity in terms of choosing what drug and not.
So Anil, you have your answer. You are the chairman of the hospital. Now have the tumor board with hepatic oncologists, show the country the new directions.
Yes.
One last question from Dr. Ashwini. 2 issues. One is most of the published data in HCC is on child A or up to B, up to 7. But most of us see patient beyond it. Is it safe to legally give them this? Number 1. Number 2, the type of dose which we give, because the established dose is say 800 milligram in the Lovett's paper. But the type of dose which we give, say 200 to 400, which most of the patients do not tolerate, is that efficacious at all? And then we'll wind up.
No, I think we have tried in patients who are intolerant to sorafenib, and this is my personal opinion, in a post-transplant setting and even in a pre-transplant setting, in a post-transplant setting because they are on immunosuppression and other medications, in a pre-transplant setting because their liver function, we typically start at a lower dose, maybe 200 BID, and we have seen people even responding. I remember anecdotal examples where tumors have disappeared on sorafenib, and you may have seen, all of you.
Yes.
So I think this is a fancy environment, microenvironment of the tumor, where response is so unpredictable from patient to patient because we're not checking how their responsive genes are in that particular patient, and patients who are not responding, whether the genes are mutated or not. So there are a lot of things which go into the response rate. But if I encounter a patient who is child B or C, say for example, CTB 9 or 10, and has a tumor and has an advanced disease, and I cannot use the other drugs, I would give a chance to the patient to give sorafenib after discussing and explaining that these are the possible side effects. And if the patient is willing to undertake that treatment, knowing that the performance status and other criteria are met in terms of bilirubin meets with, going ahead with giving the patient the therapy, I will go ahead and give the patient the therapy.
We all been talking about the objective overall response rate so often. I think I should define that this is actually important, that the overall response rate is the proportion of patients in a trial whose tumor is destroyed or significantly reduced by the drug. And that includes the partial responders, as well as the complete responders. I think that's important for our listeners to understand. That partial responder is at least 30% response.
That's right. Actually, M-RECIST criteria should be also discussed. Actually, complete response, partial response, stable disease, progressive disease, as well as overall clinical benefit, and from which you decide the ORRs.
Yes.
I think if there is no more questions, can we wind up?
Yeah, I think it is time for me to say goodbye to all. But before saying goodbye, let me point out to Dr. Ashwini Singhal that you should not be surprised that you had such a good summary. You should compliment me for choosing a very good moderator.
Right.
He's not only the doyen of hepatocellular carcinoma in India, but whole of Asia. He has a first-hand experience of handling the patient in All India Institute of Medical Sciences single-handedly in handwritten notes as my teacher for the last 30 years. So whatever he speaks, it is not a contemporary rhetoric. It is in fact coming from his heart. So you should compliment him that you had a good summary. But I will fully agree with you that even if somebody has missed the whole lecture, if he would have listened to 10 minutes talk of Dr. Acharya, he would still be benefited.
Thank
I
you.
agree. I agree.
Kind for this.
With that, I'm extremely thankful to Dr. Acharya, as always, and Dr. Sat Sanjay, Dr. Rao, Dr. Ashwini, and Dr. Robert Gish for giving us this opportunity of discussing with you the nuances of hepatocellular carcinoma and the limitations we have in the current therapy. I'm also thankful to our scientific partner, ICI, for having given us this platform. I look forward to see you again soon. Thank you and goodbye.
Thank you very much, friends. See you again and enjoy.
Bye-bye.